Dear audience, thank you for joining me in my 12 months progress report on my PhD thesis titled Oncoplastic Breast Surgery and its Clinical Significance. I'm Loretta Nyirády. I'm a 6th-year medical student and an MD PhD student at the Department of Surgery, Transplantation and Gastroenterology. My mission is, of course, to aim for perfection in breast reconstruction, and my vision is to find the best technique or techniques which result both in the safest oncological and also the best aesthetic outcome. In the last 12 months, I dove deeply into two critical areas of oncoplastic breast surgery, so let me share some insights into them. Let's begin with the first one, which is investigating the safety and effectiveness of volume displacement and volume replacement techniques in oncoplastic breast-conserving surgery. Worldwide, every 8 women has some kind of breast cancer, which could affect not only their physical health, but also their mental and sexual well-being. However, with some kind of reconstruction, we could earn them back their health, emotional well-being, and also their self-confidence. There are two distinct techniques which you could use. The first one is volume displacement, utilizing local breast tissue. Here you can see on the left side some of the methods of volume displacement. And the second one is volume replacement using perforator-based flaps. And my aim is to compare these different oncoplastic techniques and their outcomes by answering the clinical question, which is the safest and most satisfactory method or methods in oncoplastic breast reconstruction surgeries. By involving the population of women underwent breast-conserving surgery, the two intervention groups are volume replacement and volume displacement. And for the outcomes, we would like to examine primarily the patient satisfaction and secondarily the oncological safety parameters and the complications. We hypothesize that reconstruction with volume displacement is associated with better outcomes. We conducted our systematic search in 3 different databases around November. And in the search key, the first part of it, you can see the different methods of oncoplastic breast-conserving surgery, volume displacement and replacement. And in the second domain, there's the breast-conserving surgery and its synonyms. So we started our selection protocol with more than 17,000 articles. And by the end of this selection, we ended up with 46 eligible full texts. So let's look at my final results. The first one is the pooled proportion for overall satisfaction. Many women are afraid of dissatisfaction after oncoplastic breast-conserving surgery because, as I said, they are worried about the consequences, and this could affect their mental and also their sexual well-being. Here are the two subgroups, volume displacement and volume replacement. We included almost 1,700 patients, accounting for 571 events and providing a proportion of 83%. We couldn't prove any statistically significant difference between the two subgroups. My second plot is hematoma. This is a complication. Here we use the same unit, proportions, and the same subgroups. We included more than 2,000 patients with 75 events. We couldn't prove any statistically significant difference across volume displacement and volume replacement. In both of the subgroups, the hematoma incidence was really low, with an overall rate of 4%. And my third plot is an oncologically safety parameter, positive margins. Here we use the same unit, the same subgroups, and we couldn't find any dissimilarities, again, between the two subgroups. And the overall incidence rate was 7%. Because we wanted to examine a subjective outcome, which is satisfaction, it's the nature of the study that the risk of bias and also the grade assessment is really high. And we only included single-arm studies, and it's also a limitation. However, we tried to stick to rigorous methodology and a comprehensive design, and we used really large data samples, and we included every single subgroup which we could. After our thorough examination, our results suggest that volume displacement and volume replacement techniques yield equally satisfactory, oncologically safe, and complication-free outcomes. So practitioners can use both techniques equally. However, there's a pressing need to develop a universal patient satisfaction tool. Here you can see our manuscript status. Last week, we sent our manuscript to internal review, and almost everyone replied to it. There won't be any big changes, and our target journal is first JAMA Surgery. So let's move into my second project, which is investigating the safety and effectiveness of polyurethane implants compared to alternative ones in reconstruction after mastectomy. So not only every 8th woman has breast cancer, but it's also the second leading cause of death. And until these days, mastectomy rates are increasing. For example, here in a study between 2008 and 2020, it increased from 10% to 25%. And unfortunately, it has a strong stigmatizing effect for the women, which can be mitigated by reconstruction, earning pleasing results, and a better quality of life. There are many, many indications for mastectomy, but let me highlight the most important ones. For example, if it's a local recurrence, or there are multiple malignant lesions, or if the tumor is larger than 50 millimeters. And let's move into the polyurethane implants, which are regular silicone implants coated with polyurethane foam. These are showing promising results both in acute complications like hematoma, infection, or seroma, and also in later complications like implant rotation or capsular contracture. And last but not least, the overall patient satisfaction is much higher with these implants than with the alternative ones. And that's why my aim is to compare the different implant-based reconstruction techniques and their outcomes. My clinical question is that which implant-based reconstruction demonstrates the lowest rate of complications and the most satisfactory outcome in patients undergoing mastectomy. Here I would like to compare the polyurethane implants with the non-polyurethane implants and examine the outcomes of complication rate and patient satisfaction. We hypothesize that polyurethane implants are superior to alternative ones, and our clinical implication is to promote the use of implant-based reconstruction after mastectomy by understanding the most suitable approach. And in summary, these are two crucial areas of oncoplastic breast surgery. So the first one is volume displacement and replacement techniques in oncoplastic breast-conserving surgery, and the second one is polyurethane implants compared to alternative ones in reconstruction after mastectomy. And let me thank you for your attention with my quote, which is, "Every turn in life is a chance to shift into something extraordinary."
I just would like to ask you a question about the polyurethane implants. That since when are we using it, and what are the long-term experiences with these implants compared to the other ones? Or is it new compared to the other ones, or why did you choose that one?
Yes, we use this around for like 5 years or 3-5 years. And yes, as I told you, these are showing promising results in complications and also in satisfaction. Of course, there are complications with these implants too, and also dissatisfaction, but much more less than with the other ones. Thank you very much for your question.
My question is, in your first project, you showed that displacement and replacement would be equally useful techniques. Which is predominantly used in Hungary? Is there a difference in Hungary?
Thank you very much for your question. So worldwide, surgeons use most likely the volume displacement one, because everyone thought that volume displacement is associated with better outcomes, better satisfaction rates, better complication and oncologically safety rates. However, with this study, we showed that it's not true, so maybe everyone will use volume replacement as much as volume displacement.
I see. That's very good news. So you did provide new information in your research. What are the the complication rates in those, for example, in the implant cases?
Yes, the most important one is seroma. And we are thinking about a third project where we could include the seroma rates and the closure techniques after mastectomy, and which closure is going to reduce the seroma rate. So I think the seroma or the flap necrosis maybe too.
Thank you.
I have one more question about the just thinking about this last year's scandal about when there were some implants which were exploding and it was all around the news. That is there? I mean, you are taking it separated, different providers or different brands, or who are doing it, or they are all the same, and just we can take them together, like under one.
Yes, they are kind of the same. However, the alternative ones are like a group of implants, and we don't examine the brand's name or the brand itself, only the type of the implant. So yes, but maybe we can consider this variation and we can focus on the brand too.